it's my pleasure to be able to present this work to you on how guidelines can encourage shared decision-making. And as we've seen this morning, how important in our everyday practice it is to work with co-design programs with patients and certainly put them at the centre of our care. And so shared decision-making is really a key part of working with and supporting our patients in their shared decision-making. And as I highlighted this morning, when we look at evidence-based medicine, it isn't about the randomised controlled trials or the best systematic evidence in isolation of thinking about the expertise of the clinician and also, really importantly, the patient's needs, values and their preferences. So here we have the definition of shared decision-making. And really thinking about patient-centred care and focusing on the interests of the person as the first priority. Recognising and understanding and responding, tailoring care to the individual preferences, their needs and their values. Treating the person with dignity, respect and compassion. Empowering their contribution to their own healthcare, and ensuring that the person's choices and values guide our clinical decisions. So when we think about shared decision-making, what are some of the outcomes when patients engage in that shared decision-making? And I think the presenters this morning highlighting, around language, around recognising that the decision needs to be made and informed about their options, helping them understand the pros and cons of different options. But they're better prepared to have those conversations with their healthcare professionals. And the sort of language that we might use that might get in the way of making that shared decision-making. And how do we collaborate with them and give them the language and the communication, and that we are listening to their ways of knowing and valuing their lived experience. So in this presentation, I'm going to focus more on shared decision-making and the quality use of medicines, although as we've seen, it could be around decisions around diagnosis and other forms of treatment. So we use this term quality use of medicines in Australia, where the first tenet of quality use of medicines is selecting management options wisely. And that might mean that a medicine is not the first choice. And I think this is a really important concept within quality use of medicines, is that a non-pharmacological intervention might be the best option. And so that might be considering the place of that medicine in treating illness and maintaining health. But it might not always be the first option. And certainly some of the lifestyle choices, diet, exercise, stopping smoking, thinking about alcohol consumption might be more important than starting a medicine. But then if choosing a medicine is the most appropriate choice, then choosing a suitable medicine, if a medicine is that considered necessary, so that it is the best available option for that individual. What are the risks and benefits for that person? What might be the dosage and any coexisting comorbidities? What other therapies might they be on? Monitoring considerations, costs for that individual. So there's a lot of considerations once a decision has been made to use a medicine, what might be the best choice for that person. And then the third, criteria and tenet is that using those medicines then safely and effectively to get the most best possible outcome for that individual. So that's the follow-up and monitoring, minimising misuse and overuse, but also improving the person's ability to solve problems related to medication use, such as the negative effects managing multiple medications that they may be on. So when we look at the evidence, the literature would suggest that professionals often teach patients about taking their medicines. Maybe that's because of the time constraints from the health professional's point of view, that they want to ensure that the patient is taking the medicine, that they are taking into account how best to take that medicine and to reduce the risk of adverse effects. But it does tend to have that teaching focus rather than a shared decision approach often. So one of the ways of delivering information, it tends to be a one-way process of delivering that information. So shared decision-making has really been promoted as a way in which we can work with patients and consumers to really get the best clinical outcomes for them. So one of the things I wanted to share with you and to discuss today is that when we think about that and we look at the ways in which we provide that information to patients around shared decision-making, education in routine clinical practice is often provided opportunistically, it's often ad hoc, and some of the time constraints that may affect that health practitioner, particularly when providing that medicine, at each of the points in the prescribing, dispensing, administration. So most clinicians also haven't had training in some of the educational theory and behaviour change methods. And many patients now also have such access to information from social media and the internet. And much of the information assumes that, as we heard this morning, that level of health literacy. And patient education may involve information only, rather than counselling on behavioural therapies. So there are a lot of issues surrounding patient autonomy and the clinician's role to promote the well-being of the patient. So some of you will be familiar with techniques like motivational interviewing, which might be used where they express empathy, develop discrepancy, you roll with the resistance, and you support self-efficacy. So some clinicians are very well practiced in motivational interviewing and using this as a technique to have those conversations with the patient to provide the information in a way that might support shared decision-making and give them enough information for them to make a decision. So there's a lot written on shared decision-making, and I've just selected this article from the literature just to highlight some of the issues that we face when we have shared decision-making. And this was some work done in the United Kingdom, looking at long-term conditions and whether anything's changed. And one of the things that we see in this work is, again, that difference between some of the patients that feel they weren't seen and they weren't heard and they weren't given the opportunity to have those conversations with their health professional. And then others where they wanted to leave that decision to their health professional, that they thought that the health professional was best placed to make that decision. So we get that continuum of what patients need, and again, we have to be respectful of that. And also some patients, they will have different points in their care journey when they might want more information. It might be a different decision in terms of shared decision-making when it might be about preventative treatment, or it's an additional drug therapy to medicines that they're already on. And we've seen work published in this area, particularly looking at those differences between at one stage of your life where you might be very informed about a particular condition, or when you've got a very complex, maybe complex chemotherapy or some of those other areas. So for the same person, they might have different expectations around that shared decision making. And the guidelines may be about lifestyle and their shared decision making in that, where the information is perhaps more accessible for them. As I said, compared to maybe a complex chemotherapeutic regimen to treat a cancer. So again, just to reinforce those points, is that when we look at that shared decision making, it can vary from individual person to individual person, but within the same person, they can also have different requirements around shared decision making. So, how can we support shared decision making? There is increasingly more and more portals, websites, information available for patients that mean that they can engage perhaps before they even see the doctor or the other healthcare professional. In many countries, and in Australia, we have the My Health Record, where the patient can look at their own personal health record that might inform some of those conversations. We provide them with questions that they might want to ask of their health professional, and using language that means that those responses make it more accessible for them. Also, some of those portals mean that the health professionals can communicate electronically with the patient, and so there can be a conversation about that shared decision making. So that's secure messaging. But also, it can be important that we remind the health professionals to actually involve the patient in a busy day of a healthcare professional, that they may not engage in that same way. So having prompts or reminders and recalls, and even included in the guidelines, those points at which there might be decision aids that help support that conversation and support that shared decision making. So we've recently been exploring an approach to try and enhance the accessibility of that information for patients upon which they can make a shared decision. And we've been using the principles of academic detailing, which I mentioned this morning, which has largely been developed for prescribers. But more recently, we've used the principles for these education approaches with our patients. So whilst academic detailing, as I said, has been really largely trialled and the evidence base is with clinicians, we thought that the principles of academic detailing, which include listening to the needs of the individual and tailoring messages to influence behaviour to the sort of socially desired outcomes, might be an approach that we could use to support shared decision making. There is overlap with techniques such as motivational interviewing, and those of you who are familiar with that, motivational interviewing is also an approach where the change is elicited from the client and not imposed. So this approach of personalised education or a structured educational visit, really taking the time one-to-one with our patients, or it might be including other family members or caregivers. But importantly, in this shared decision-making process is timing at the convenience of that recipient. Because sometimes in the busyness of the practice, in the consultation, in the hospital, in the ward, in primary care, there can be a lot of other things happening for that patient. So we tried with our personalised approach to make it as close as possible to where that decision needed to be made. And the key points for decision making, trying to make them succinct and brief and directly relevant to patient care. Not dissimilar to the presenter this morning who talked about the sort of nudge, making it easy, making it timely. making it actionable. So what we were trying to do in this work where we were applying these principles is to move an interaction beyond just communicating information. Many of our interactions with patients around medicine sometimes can take on a more transactional approach rather than thinking about that relationship and building that relationship with that patient so that they feel they have the trust to ask those questions and to contribute their views. So we wanted to, again, use these principles where we weren't imposing our views, that we were understanding where they were at, what their current behaviour was, what their lived experience is, and valuing that. Understanding where they're currently at, valuing, as I said, their perspective and their experience. So in this technique, we were trying to encourage and achieve voluntary action, not coercion or enforcement, not imposing our way of doing something, but really using this personalised approach. We talk about personalised medicines, but really this was now thinking about personalised education to support shared decision making. And so what I've just trying to highlight here is just very simply thinking about the context in which that might take place. When we think about shared decision making, really being creating an environment, creating a situation in which that can take place. In this technique that we use, we were, and I'll come to talk a little bit about that, but I think the context is really important if we're going to build trust and establish our credibility and that we're listening to them. And then this principle of exchange, that it's not about telling or imposing, but really very much about eliciting needs and meeting those needs, and sometimes presenting options and exploring and communicating strategies. And also then gaining commitment. And that gaining commitment might be a process across time with a patient around shared decision making. They might want some information and then follow up with further questions. So using guidelines to support shared decision making and making those guidelines in a format that means that the language is accessible, but that they are available when the patient needs them and that they have time to consider them. So in developing a program to support shared decision making, I just wanted to share with you a program that we recently undertook, and it was using the principles of academic detailing to try and inform in shared decision making. So first of all, we had to dream and to get the funding and then to design the program and then to build the program. And we related it to atrial fibrillation because we can see that atrial fibrillation is in our country and internationally, it is the cardiovascular condition that is rapidly increasing, and it's the most common cardiovascular cause of hospitalisation. So you can see across those last few decades the increasing burden of atrial fibrillation. And we've now got increasing medicines to, we've moved from the warfarin era into the direct-acting oral anticoagulants to reduce that burden of stroke. So we thought that we would design this program around atrial fibrillation, using the principles of academic detailing and personalising it for that individual patient. So in that personalised education, it's about providing a program where we went and visited individual patients, and we're now looking at that using a telemedicine approach, but this was pre-COVID, where we had the opportunity to meet with the patients in their own homes as part of this project. And we defined clear educational and behavioural objectives, And we established credibility through respective organisational identity and the current available guidelines. We referenced authoritative and unbiased sources of information so that we could present both sides of any controversial issues, and again, using the guidelines. And in this approach, it's about actively stimulating participation in that interaction. So again, those principles of shared decision-making in which it's a conversation. It's not about telling the patients, but presenting information and listening to their views. We use concise, graphical, educational materials that highlight and repeat essential messages. Again, in accord with the best available guidelines and using those guidelines for that consistency. And providing positive reinforcement of any improved practices at follow-up visits. So we designed this home-based intervention using patient-centred structured educational visiting, and our goal was to reduce hospitalisations and presentations to the ED department and improve quality of life. This work has been presented at the Cardiac Society meeting, and some of it will be published soon, and some of it has been published. But again, we developed some key messages for this program. We developed concise educational materials, and it was about highlighting to the patients that with regards to atrial fibrillation, we wanted them to understand their condition, to be able to know what their symptoms were that were their usual signs and symptoms when they experienced atrial fibrillation. We gave them skills to estimate their pulse, and they had a personal plan, but they could telephone the helpline and reach a cardiologist if they needed to. We developed some a priori key messages, but even though we had developed those a priori key messages, it really was also designed that they would be presented in a way that met the individual needs of the patients that we were visiting with. And they highlighted things like that there were these medicines that would reduce their risk of thromboembolic stroke, but also putting it into the context of what is the risk, what is the benefit, and that they might be able to reduce their risk by becoming more aware of diet, lifestyle, alcohol intake, if that was a precipitant for their AF, and that if they became aware of their symptoms and their usual symptoms, that usually AF was not a medical emergency. But again, being very cautious with that and giving them the skills to know that if they were concerned at all, then they would need to go to hospital if it wasn't their usual symptoms. So we were able to do this as a randomised controlled trial, and we randomised patients into that personalised intervention and usual care, and they had 2 home visits. And so this personalisation of patient education to support shared decision-making, underpinned by those principles where we paid attention to the context and understood the context where those conversations were taking place, the connection with guidelines and also the commitment. And I've just highlighted here some of our learnings around some of the key elements in that context, connection, and the communication and commitment that was important. And as we look at those study results, we have been able to demonstrate significant reductions in emergency department presentations of those patients who participated in this personalised education and shared decision-making. So it really highlighted that working with the patients, giving them those skills to manage their condition, the opportunity to ask questions, has led to very significant reductions in presentations of those patients with atrial fibrillation presenting to our ED departments with atrial fibrillation. And I think It really highlighted that using these principles and assessing the patient's prior knowledge and motivations and encouraging them to be active participants, really focused our attention on just a limited number of key messages. And again, as echoed in the presentation this morning. But it's really important to tailor to the individual needs and understanding and the level of health literacy. So this is an approach that it does take time, but it really supported those individuals and it led to reduction in health service utilisation. So patients really felt that they were valued, that it was important enough for them to be afforded the time of the health professionals to have these respectful conversations. And really that is at the foundation of that shared decision making and built on that trust. And that can be built over time. So moving from a more transactional approach to more of a relationship-based approach with our patients. Because traditionally, for a whole variety of reasons, healthcare is organised often around the operational and professional needs of the clinician and the healthcare system. So in our patient-centred, structured educational visits, it's really very much patient-centred and it's not organised around them and their needs. And I think it's one of the outcomes from the last 2.5 years is how we've been able to embrace telemedicine to support those patients in an ongoing way and using this technique. And I think that this news article that was published after our study was finished and we were starting to write up on the results. And you can see here in the news clipping that this patient who was a participant really felt that their lives had been very impacted by their symptomatic episodes of AF. But when they were involved in this, they were included in the decision making. You can see her comments there and her smiling face. So thank you very much.